Hello everybody, I'm back. Dr. K.K. Agarwal, President Heartcare Foundation of India. And you are watching Med Talks with Dr. K.K. Agarwal, 7 p.m. show every day. And today is going to be 46th episode, special COVID edition. And this edition basically is to take the fear out of the mind of the people and make the healthcare provider understand the basics of, I would say, COVIDology. It's a new branch of science. I'll call them as coranxiety, and now I'm calling it as a COVIDology. And before we discuss the subject of the day, let's have the headlines for the day. An analysis of 7 international trials reveal that corticosteroid reduce the risk of death by 20% in critically ill COVID patients. In India, we have seen that even in moderate cases or at the time of anoxia, they are reducing mortality. Due to sudden death of COVID-19 patients, the Health Ministry asked doctors to strictly monitor patients with risk factors or with prior comorbid conditions such as chronic lung disease. And we know today the time to develop pneumonia is day 3. So day 3, day 4, day 5. If you pick up pneumonia, if you do 6-minute walk test, if you pick up warning signals, you may be able to provide early treatment. Hospital beds running low again in Delhi as daily cases crossed 2,500 mark for the first time in the last 61 days. Is it the continuing first wave? Is it the new wave? Is it the second wave? Is it a mutated virus? We don't know. India considers indigenous manufacturing of heparin by allowing import of raw material from countries including those in South America. Delhi Disaster Management Authority directs state authorities to ensure strict testing facilities at all railway stations, interstate bus terminals, and large construction sites. Therefore, all the migrant population who are coming back needs to be tested. Let's go to the subject of the day. Molecular testing, antigen testing, antibodies testing, sputum testing, throat swab testing, nasal swab testing, and the blood testing. Is there a role of testing for other secretions in the body or not? We will try to answer all such questions. And I have an expert with me. Let me introduce my expert, Dr. Anita Chakravarti. She is a former professor and HOD microbiology at Maulana Azad Medical College and Associated Hospital. She has established the Diagnostic Virology Lab at MAMC, and now she's an expert in establishing COVID-19 labs. Her main research interests and contribution have been in clinical virology, and she is recipient of state and national award in the field of her virology work. Thank you, madam, to be here with us. Coming back to the subject directly, can you understand the structure of a virus in terms of when we test? We can test different parts of the virus. Can we have a brief about the structure of a virus?
Yes. Actually, the viruses which cause human diseases, you categorize it into DNA and RNA viruses. And they have a core. And this is covered by a capsid. So that's a nucleic acid core. And then you have a capsid. It's just like the spinal cord and the vertebral column. So that is protecting the nucleic acid. And then above that, you have the outer layers or membranes. There are some viruses which have envelopes. There are some viruses which don't have envelopes. And there are some viruses which have spikes in them. So these spiked viruses are very important because spike is the main organ by which they attach. They have ability to attach to RBDs or receptor binding domains inside the cells. So if we are coming back to coronaviruses, this is an RNA virus, and you have alpha, beta, gamma, delta coronaviruses. But the SARS coronavirus 2 is a beta coronavirus. And this coronavirus, as we all know, this was through bats and through pangolins. And in Wuhan, I think they use these pangolins for medicines. So probably it infected man because of these pangolins. And the coronavirus structure also, this has a RNA. The RNA is a single stranded, and it is called as a positive stranded RNA. Positive strand means it's more infectious than a negative stranded RNA, and it has many proteins on its covers. So I shall talk to you about some of the important proteins which are also used for various tests. So as I just told you, the main outer protein, and it looks just like a corona. So it looks like you can say a crown, and the protein is the spike one, and it is broken down into two segments, the S1 and the S2 segment. And the S1 segment is the main segment which binds to the ACE2 receptors, which you must be hearing on the cells. Usually it's the pulmonary cells, it could be renal or gastrointestinal cells also. And S2 receptors, they help in the fusion of the virus and facilitate both the viral and the host cell fusion. And then you have other proteins like the membrane protein, which gives it a structure. And you have a E protein, which is very small. And this is the envelope protein. So normally the virus gets the envelope protein when it is coming out of the cell. So that's a part many times of the cell. And one has the nucleic acid protein also. And this is associated with the viral replication. So when you see a virus genome, it has open reading frames, it has structural proteins. The frames have genes for structural proteins and for non-structural proteins. So structural proteins are these proteins which are coding for spike, for envelope, and for nucleocapsid, etc. These are the structural. And the non-structural proteins are the proteins like proteases. So these are the non-structural proteins which help the virus in replication. And each of the protein has its own importance.
So when we talk about non-structural proteins, what about ORF1 and ORF1AB? Are they non-structural proteins?
They are non-structural protein, and they're very important non-structural protein because many times these are the ones which are species specific. So when you are going to do some test, because coronavirus is there, it causes infection in human beings, the beta coronavirus, it could be respiratory infections, it could be mild also. But if you have to definitely label it as coronavirus 2, then one has to use these non-structural proteins also to see the presence of ORF1A, 1B, or RDRP, which is another very important protein.
So how are ORF1A and ORF1B are related to RDRP? Are they precursor to each other, or they are different, or RNA
no, they are polymerase that helps in in the virus multiplication. So it's it helps in the replication of the virus. And ORF1A and 1B are at the ends. So they also come into play during the transcription and other processes which occurs in the viruses.
So when it comes to these proteins in the body, say for example, are they released in the body at the same time or at different times? Say E is common to all coronaviruses.
Yeah,
okay.
Yeah, yes.
But then RDRP, ORF1AB, SMN, they are different genes. Do they appear in the body at the same time when I'm testing, when I'm amplifying it on a test? Do these genes appear at the same time or differently?
No, they appear at the same time. And it's important that the testing is done in a particular period of the disease. Like we all know that when the virus infects, immediately in almost all the cases, you won't get the infection. The infection will occur only after a lag period of 4 or 5 or a few days, but the virus is there. And after that, these viruses are present in the respiratory secretions, and they will be present in the nasopharynx. So these viruses are usually, they pick up by the fourth or fifth day, and by the ninth day, they are not viable. So you can pick them up even after for a long period, but the viability of the virus will not be there. They won't be the living virus. You can pick up the particles of the virus.
So if I say one thing is very clear, after ninth day, the virus is non-replicable. And when we are detecting after 9 days, a person may have a positive detection of something for the next 3 months. What are we detecting there? Is it a remnant that we are checking RDRP, SMN, everything can be present after 9 days?
Yeah, usually the remnant of the virus, but they are not present up till 3 months. They could be, in a very few cases, extremely few cases, they could be present up till 1 month. So generally, you cannot see them. That is the thing. The second thing is, it's very important. One has to know how much of the virus is present. So this is what you see in RT-PCR when you do the amplification of the virus in the amplifying system. Then you see the quantity of the virus which is present. So we normally report as a certain CT value. So in the CT value, when we report, we always say that it has in India, we say that it has to be below 36. So CT value means the cycles it undergoes, cycle thresholds, CT means, and it is the number of cycles at which the virus can be found. So the virus below 36 is important, and one has to see minimum of 2 genes. So envelope gene would be present for other coronavirus, but you have to see the presence of RDRP gene or the 1A ORF1A gene or the ORF1B gene. So the other, like new N gene also could be present, and you couldn't see the presence of envelope gene, but they would not be the confirmatory test gene. For the confirmatory test, you have to do for the RDRP or the ORF1A or the ORF1B. So in India, mostly we do for the RDRP, and it also depends on what kit we are using. So there are so many kits, and these kits, ICMR gives us the guidelines. They validate the kits, and those kits are the ones which are being used, so that
जो
results are generated.
लोग इस प्रोग्राम को देख रहे हैं और उनके ऊपर से जा रहा है ये लैंग्वेज, तो एक आम भाषा में समझाता हूँ कि जब पुलिस रेड करने आती है, मान लीजिए मैडम ने कहा 36 स्टोरीड है बिल्डिंग, और जो चोर हैं वो ऊपर से कूद रहे हैं, यानी कि छत से एंटर कर रहे हैं, तो पुलिस जाके देखती है कि कौन से फ्लोर में जाके चोर मिले। अगर वो 14वें फ्लोर पे मिले, इसका मतलब है 14 से लेके 36 फ्लोर तक चोर भरे हुए हैं, उन्होंने चोरी कर ली, क्योंकि वो ऊपर से नीचे आ रहे हैं। सो दैट्स सो यू नो कि जितने वो नीचे पकड़ में आएंगे, उतना चोरी उन्होंने ज्यादा फ्लोर में चोरी करी, उतना वायरल लोड ज्यादा है। सो ये आम जनता को समझाने के लिए मैंने इसको बताने की कोशिश करी, and that's how microbiologists will check the viral load. Now, what are the errors in that viral load? It can be kit dependent, we know. We also know viral load, whether it is more contagious or whether it is more virulence. There is no study to dictate that mandatorily. We know that, but I'm only trying to say is, even if it is different from various labs, so there is a cutoff. Suppose the cutoff of the most of the labs is 35. Suppose the CT value is 30, so I say -5. So if a lab's CT value is different, so do you think that minus figure will always be the constant of various reagents? So everywhere from the cutoff, suppose somebody else's cutoff is 40, then their -5 will be 35. 35 cutoff -5 will be 30. That 30 and 35 will be comparable to each other or not?
No, it is. You see, every kit has its own controls. Kit controls also which run. Yeah. So you have your validity, your internal controls, and you also have to use certain other controls also every time you're running these tests, because they're very sensitive tests. So they can even pick up the wrong things. So therefore, you have to be very when these tests are being done. one has to be, the lab has to get many approvals. They go through proficiency testing regularly in validated labs. There are labs set. So every time one lab is approved, that lab sends its samples there to see whether the results they're generating are proper. So mainly the kit which are reliable are being used, and below 36 is the cycle most of the kits take as the positive.
I take a simple example that a patient who is positive, suppose on day one, CT value is 20, and after 2 weeks he is still positive, the CT value is say 30. So I know the virus load is reducing. And the third, it becomes negative. That means CT value has crossed 36 or 40, whatever is the cutoff value, or it is not there. 1 month later, he develops symptoms again, and RT-PCR is positive. After 2 negative, RT-PCR now becomes negative, positive. So unless I know the CT value, suppose the CT value now is 14. Suppose the new RT-PCR value is now 14, then only I can pick up a reinfection. Otherwise, I will never be able to. Because there are 4 cases of reinfections which have come, one in Belgium, one in Netherlands, one in Hong Kong, one in US. So if I want to pick up a reinfection, the only way I can pick up is, one of the criteria will be that after 2 tested negative RT-PCR, I get a positive with a very low CT value. If it is a very high CT value, I can still say that it is a remnant of the previous one.
Yes. No, but the thing is that when you get reinfection, it's not only the CT value which is important. If the reinfection, you have to know what virus sequence is there in this, which is the virus which is reinfecting, because there are very, very few cases. I think the Hong Kong study only was a good study in which they went into details about this disease, and they followed the patient properly. So in that Hong Kong study, they could almost prove that it is reinfection. Otherwise, many times the viral particles remain and one feels that it is a reinfection. But there is a possibility that there could be different types of viruses which are coming, different quasi-species which are occurring, different clades are there. Though, of course, reinfection is at present not that much.
Agreed, Anitaji. But my only trying to say is that as a clinician, if I want to suspect a reinfection and send them for genomics and send them to find out the gene sequencing, then one of the factor is re-symptoms, rising CRP, C-reactive protein, symptomatic rising CRP, and again RT-PCR positive. In such cases, and if I find that the CT value is very, very, very low, these are the cases I need to send it to the government to find out, am I suspecting a case of a reinfection or not? I'm only talking about screening for reinfection, because these are the cases where we need to know about whether it is reinfection or not. So coming back to, so one thing is very clear, that CT value does help in such cases, and CT value does help if you find that a patient is persistently positive, remnants are positive, then their CT value invariably will be higher up. Third is that we do know that, I mean, I'm just asking, madam, that in immunocompromised person on steroid, person on pneumonia, that virus get kills on 9th day, is it valid there also? When we say the virus doesn't stay in the body for 9 days, is it also true in a situation like immunocompromised, uncontrolled diabetes, or a patient with steroids?
Ideally, in an immunocompromised patient, there is a possibility of the virus staying for a slightly longer period. But generally, what happens is that the type of presentation is the one which differs when you're immunocompromised. Generally, virus viability after a certain period is not there. After 8 to 9 days, it is not there. After 9 days.
So
that's almost
yes.
But the host, the body reactions of the host, that manifests in a different way. It is the reason for the strong severity of infection, because we know the viral load does not link with the viral severity to date. Later on, if the findings change, it is different. But there is not so much of a linkage of amount of virus with the severity. Even it has been seen that very less virus could cause very severe infection in a person who is, say, highly immunocompromised or severe diabetic or having some other type of comorbidities.
Well, my one more question is how early the virus can go. You say by ninth day virus is killed. How early the virus can be killed? Can it get killed? Specifically, I'm talking about children where it gets cleared. Symptoms are lasting only for 2 days. Can it happen that in children it clears earlier than 9 days?
You see, children here are not clearing it very early. Therefore, they are the ones who are transmitting infections if they don't have symptoms. So they may not be having the symptoms, but they still have the infectious virus. Virus has a cycle, so it won't be prolonging for so long. It won't be
So I'm only
present
trying
for
to say
so. The
is
viability will not be.
how early the virus can disappear. If it disappears, it gets killed by 9 days. Can it, there has to be a duration. There has to be a curve that it start disappearing, and by ninth day this is over. So what is the average time? Can it disappear in
Normally,
some
what
cases
happens
in
is
a day?
once, yeah, the virus starts before the person develops symptoms. It goes down by the eighth or ninth or 10th day. After that, you have your antibodies coming into play. Therefore,
So,
that is the time when one has to ideally do the antibody testing. So that's how
but,
the curve occurs.
but here the antibodies. Let's come back to the second part of the gene, and that's the rapid antigen gene. But after a short break. You're watching Med Talks with Dr. K. Agarwal, 46th episode in a row. And we are talking about molecular testing. And our expert is Dr. Anita Chakravarti. मैडम ये जो रैपिड एंटीजन हो रहा है जिसमें हम लोग सिर्फ नोज का सैंपल लेते हैं ए वाई ओनली नोज बिकॉज हम थ्रोट को पूरा मिस कर रहे हैं और उसमें हम कौन सा एंटीजन टेस्ट कर रहे हैं दैट्स आई एम टॉकिंग अबाउट nasal rapid antigen test. I'm not talking about the blood test. उसमें क्या टेस्ट कर रहे हैं?
So here we are testing for the protein, spike protein, and ideally this rapid antigen test is a point of care test. So this is a very what would I say? This is a very specific test, but it may not be very sensitive because here we are not amplifying the virus. In RT-PCR, in the molecular, in the NAT test, nucleic acid amplification test, what we do, they get amplified. But in this, we do not amplify. Therefore, the sensitivity could be around 50%. But once the specificity is almost, you can say about 98 to 99% in these tests. And they are very good tests because if you can give an answer within a few minutes, say 10 or 15 minutes, so it helps. You can contain the other person from getting infected. If there is a positive person, you can immediately like start with his treatment. You can isolate, and whatever the guidelines are, that can be followed. So that is important.
Why only nasal swab? Why only nasal swab? Why can't we use both the swabs here in a rapid antigen? Why in a RT-PCR you take two samples and in this you take only the nasal swab?
Actually, they have some types of buffers. We in the RT-PCR we are using the viral transport media, and in that we are lysing it. Here it's a different type of buffer into which you're going to put the nasal specimens, And actually, nasal specimens, as per the whatever the antigen kit literature, because there are many antigen different types of tests. You can have ICTs and you can have those cartridge tests. So, or like those things which you get in the pregnancy test, you can have those type of steps in that also. So, the probability of isolating the antigen in the secretions, nasal secretions, becomes more in this. That's why they try to use this, and the lysis buffer which is used. So they are the ones which expresses out these antigens properly.
So basically, we are checking the spike protein here, and so spike protein which is specific to COVID-19. So therefore, that's being done. What about the antibodies test? We have people say that IgM is not reliable. People say IgM and IgG may appear same time. IgM may appear after IgG. IgG may appear, may not appear. If it appears, it disappears early. How reliable are these tests? A. And number two, on what, because they represent only the humoral antibodies. They don't tell us about the memory T cells and memory B cells. They are not talking about cellular immunity. How reliable they are, and at what time they will appear. What is the ideal time to get it done? Is it day 14, 21, or 28? Because we have seen by day 14, most of them are not appearing. And so we have changed our criteria in clinical practice to day 28.
Yeah, actually, that is a very good, in fact, because as with other antibodies, also they will be positive only after the first week. So the rise starts after in the second week, in fact, in the mid or the end of the second week, and there's a gradual rise, and the peaking up becomes possible at the end of fourth week. Now, IgM is there, but it lasts for a short time. In many cases, it has also been seen that IgG appears before the IgM. Therefore, IgG becomes a more reliable antibody to pick up, and the testing should be done in the second week if you want to pick up the IgG early and if it is possible to pick up. But the peak occurs only after the fourth week. And more important is that why do we want to do the IgG? So basically, we are doing the IgG for surveillance, just to see how many people have infected, or whether we want to use them as plasma donors if the quantity of the IgG is good enough. Again, here again, you have different kits. So there has to be a kit which will measure the level of IgG. And we also have our Indian kit, Kavach, it's called as, which measures the level of IgG. They are being used for the serosurveillance. So IgG is definitely a better indicator of, and they would say that it's a passport and all
For
that.
for us
Yeah.
in the clinical practice, where are we using a, say for example, this patient who developed, suppose a patient, I'm doing both antibodies and antigen, both of them are positive. That's the situation where, because suppose a person says, I am having a symptoms today of corona-like symptoms, and he said, I had the same corona-like symptoms 2 months ago also. So that means at this moment, is it, and if it's RT-PCR positive, I want to know, is it a RT-PCR positive today, or did he had a RT-PCR positive 2 months back and the remnants are persisting? So I need to know with the antibody test. So today, a time has come when the disease is 6 months old, that like we do it NS1, IgM and IgG antibodies in dengue. Now, time has come for us to do antigen antibodies together. It may help us in differentiating many types of clinical situations. Like this patient, which I talked about, reinfection, is only possible if I see that antibodies and antigen both are positive. Then only I can consider it as a reinfection. So from seroprevalence, earlier phases, now clinical utility of antibody test is increasing. And then we also see whether the antibodies, because we have seen is more the CRP, more the antibodies. That's a clinical anecdotal observation. I'm not saying this is, we are seeing that patients who have loss of smell, loss of taste, they may not develop antibodies at all. Children may not develop antibodies at all. Milder infections are having milder antibodies. And more the pneumonia, more the CRP, more the IL-6, more the antibodies are being produced. And we really don't know whether these antibodies are really neutralizing antibodies or not. We have no evidence to say. We are not doing a titer. We are 1:2 like that titer we are not doing. And so really, and we are not measuring any cellular immunity. There is a Singapore study which says that SARS-1 virus immunity is still present in the people in the country. So therefore, still some way or the other, it does help. But I want to ask a question is, what is this business of total antibody? People are doing IgG, IgM as a total antibodies. What's the need of doing a total antibodies? We should do it separately, IgM separately, IgG separately.
There are various different types of kits. So for a short time, IgM and IgG could be positive for a short time, but IgG is the one which stays positive for a longer time. And the other thing is, studies nowadays, they say that the antibody lasts only for about 3 months. Because see, the disease is there since say January, and now it would be about 8 months, and the antibody testing has started later. So how much protection the antibody is giving, one doesn't know, as you have just said, that these are not neutralizing antibodies. So these are humoral antibodies. For protection, definitely T cell would have some amount of, it has to come into play. And for neutralizing antibodies, you cannot do such simple tests like ELISAs. We would have to do plaque neutralization test. Plaque neutralization test is very sophisticated. It needs a lot of skill. It's done on certain cell lines, like viro cell lines in which these viruses will grow. So there are huge cell lines. There are 3-4 types of cell lines in which you can grow coronaviruses. It takes almost 96 hours for the viruses to grow. So the neutralization, this is not a neutralizing antibody. It's just showing you that the immune presence, that the person has had an infection in the past, he has the antibody. And till date, we are happy that if there is antibody, maybe you're safe for about 2 to 3 months. But what next? So that's the question.
Then when you ask for an antibody, they says which antibody, which testing you want, CLIA or ELIA. What are these differences? What is CLIA?
No, CLIA is definitely better. Chemiluminescence is better than enzyme-linked immunoassays. It's more sensitive. So and it's of course expensive. So
but why should they ask? No, but most of the people say dono kar do. What's the need of both of them?
No, there's no need of both of them, and then the lab is making money. I mean, you can do one of the tests.
So that, and if you have to choose between the two, you say CLIA is better.
I would say CLIA, and it's expensive more than the routine ELISA.
So I want to come back to one more thing is that when we talk about humoral antibodies, we have thymus gland in the child. We have thymosin alpha as the hormone in the children. Do you think that when it comes to a disease like this, where you say that immunity is lasting only for 3 months, I'm talking about humoral, cellular, I don't know. Do you think a time has come for us to revisit, like you give testosterone replacement in adulthood, that you give recombinant thymus hormones in adulthood that may help in increasing the immunity, lasting it longer? I'm putting a lateral thinking theoretical question that is there a possibility of a thyroid extract in the form of a recombinant hormone to be given to boost this immunity, or there are any other ways of boosting this immunity? Like you have vaccine boosters, you have conjugate boosters, there are nanoparticles of spike protein coming with a conjugate to boost the immunity. So you have vaccine boosters. Why can't there be a similar type of a boosters to boost the natural immunity of a virus?
About this, I will not be able to say because I'm not into it. But yes, they even say that BCG gives you some amount of it's an immunomodulator. So there are vaccines which they say somewhere I read they said measles thing could also be. So hypothesis and the basic idea is that since we do not know and we are not aware about which antiviral is going to work on which patient, there is no definite treatment against this disease. So the idea is to boost the immunity to fight the disease. So that's the concept.
I want to
And
come back to. I want to end by one more issuing a topic and raising a topic, and that's mysterious virus. Now, if it is a virus, the disease must end in 2 weeks. It's lasting for 3 months. We have a post-viral persistent inflammation. If it is a virus, it should increase the lymphocytes. It reduces lymphocytes. If it is a virus, it should not increase procalcitonin. Some cases it is. If it is a virus, it's not supposed to have acute phase reactant, but it is raising inflammation, it is causing inflammation, it is causing thromboinflammation. If it is a virus, it doesn't require an antibiotic, but this virus requiring antibiotics. If this is a virus, why it is sparing laryngitis, why it is sparing arthritis, totally spares laryngitis, larynx, mediastinitis is not there, mediastinal lymph nodes are not there, pleural effusion is not there with the pneumonia, pericardial effusion is not there, ascites is not there. So it has a lot of mysterious actions. If it is causing hypoxia, why it is sparing the CO2? We have been, I mean, there are lots of theories coming in. I'm only going to say is this virus sometimes behave like a bacteria, sometimes behave like an HIV. It's a mysterious virus. Do you have you ever heard of any other virus so mysterious that it can present anything in the body, spare anything in life?
As a microbiologist, I can say that along with viral infection, superadded bacterial occurs. Therefore, the antibiotics are given. The other thing is that you have ADE occurring. So AD is a very important phenomenon. And when you have these cytokines come into play, just like in dengue, you see the same type of vasculitis and bleeding. So and you also have hemorrhages, and a person can have strokes, and there are so many patients coming with cardiac cardiac diseases. So this virus is, and I agree with you, it's a very atypical virus, but the type of presentation can be seen in other viruses also. Why is antiretroviral acting in some patients when it doesn't act in other patients? This is also not known, because we do not have specific monoclonal antibodies, we do not have specific antivirals to fight this particular virus. So it goes to multi-system disorders. This is known. And the other thing is that definitely it attacks those cells which has ACE inhibitors. This is very clear that it is going to act at that level, because these are the places where the spikes can bind, So therefore, most of the vaccines and all are being targeted here so that it doesn't enter.
So my last thing is virus doesn't kill. What kills is immunological reaction. What kills is production of IL-6 and TNF. Do you feel that everything it does, it just ignite, it works like a matchstick? It takes a matchbox, works like a matchstick, ignites the IL-6 production and goes away. And that IL-6 reaction, which can persist for 3 months and goes on causing the symptoms. So do you think that IL-6 is the culprit here, or TNF is the culprit here?
It's a play of the pro and anti-inflammatory cytokines. So, of course, IL-6 is very important, and they use anti-IL-6 also drugs to see that the effect is slightly neutralized. But it's a play. It's a play of many. Even interferons are produced. So there are many factors which are produced. IL-2 is also produced. So many cytokines are produced. So it's very much like what you see in AD due to dengue. And once they are produced, then they become difficult to treat.
So basically, its role is to ignite production of cytokines, which are both inflammatory and anti-inflammatory. And when they try to commit suicide, they become a suicidal bomber, they cause a cytokine crisis. My last thing is, when we talk about chikungunya, we have persistent arthritis in chikungunya lasting for a year. What's that? Is it a post-viral immunological reaction? Because here also we are saying post 9 days, for 90 days, we are getting recurrent symptoms. We are seeing recurrent inflammations. We are seeing rise of CRP. So what is this phenomena? What is this post-viral phenomena?
In chikungunya, this has been seen quite commonly, and especially in the elderly age group, it is seen, and it targets the synovial membrane. That's one of the hypotheses, but there are many other hypotheses. It's not definitely known why it occurs. In this case, of course, arthritis is usually not the manifestation with coronavirus, but yes, a lot of fatigue would be important manifestation, and you must be seeing it in your day-to-day cases that people are exhausted, and many times just when you test them, then you find it's they are coronavirus, SARS coronavirus 2 positive. So persistence of infection is may not be because of the virus, but maybe because of certain biological effects occurring in the body because post-viral, episodes which can occur. So that could be one of the reasons.
Therefore, I say it works like a matchstick. It ignites the fire and it goes away, and it all depends upon the fire, what damage it is causing, and whether you have been able to extinguish the fire or not. And modern medicine has no answer, but Ayurveda says it's Agni. It ignites the Agni, and the ignites Agni continues. Ayurveda says that we have 5 basic areas where the Agni and the Pitta is present. And these 5 areas are Alochak, eye. It has Brajak, which is skin. It has Pachak, which is your stomach and small intestine. And it has a Ranjak, which is your blood and gallbladder and the liver. And then it has a Sadhak, which is the heart and the pulmonary circulation. And if you see, you'll be surprised to see that all the areas which are mentioned in Ayurveda as the Pitta or the Agni located areas or the Agni fire, or the what we call them as different types of Bhuta Agni and the Dhatu Agni, they all have the same manifestations which are occurring. Maybe that this virus only ignites the fire within our body, which we detect as CRP, which is indirectly dependent on IL-6, because IL-6 goes to the liver and forms a C-reactive protein. And this IL-6, interferon, and the TNF grouped together probably maybe having the after effect after the virus is killed. So don't get upset if you have recurrent symptoms after 9 days. Your CRP may rise, your IL-6 may rise, you may have recurrent symptoms, and you may also have a remnants of the virus staying there. Control them. That's all for today. Let me thank Dr. Anita Chakravarti to be here with us and for a beautiful interaction on this particular subject. To all my viewers, if you think that this was a good discussion, kindly forward it to your friends. We'll be back tomorrow, 7 p.m. with another show. Namaskar.